time. And I do not have the committee minutes ready. I will have them, God willing, by the end of this week. Life has been just so much fun. Chairperson's report at the last meeting, we had someone from DOHMH and from the faith-based Office of Faith-Based Health, and it was a fascinating, view into where they're going. It's a brand new deputy commissioner, and she is looking to really work with us more closely on healthcare disparities. And the month before that, we had Hassan Navid from Hate Crimes, and really they're going to be working with us hopefully closely as we begin to develop the plans for this eventual forum that we're going to be able to do in the near future. And that's really all I have to report on. It's still a little bit early. Brett, when will the senator be ready?
He should be joining in a couple minutes.
Okay, so we can jump around a little bit. One of the things that I was David Gelfand reminded me about.
I'm sitting next to him. Yes. Okay.
Yes. The discussion of capital and expense budget priorities. So the way it was explained to me, and I don't really quite understand it completely, but we have the right to request from different agencies within the city government some expenses or some requests for strengthening healthcare and hospitals in the area. Obviously, we can't request for an entire new hospital. I don't think that's going to work. One of the suggestions I'm going to throw out there to start the discussion is that we can request from the Office of the Prevention of Hate Crimes for them to provide us funding for materials and for the forum and for other things around this issue of hate. They make small grants of $10,000 to $15,000 to $20,000. I think that's something we can certainly ask for. I was also told by David that the Borough President's Office really wants to minimize the amount of requests that go out to various different government agencies, because most of them get hundreds and hundreds and hundreds of requests from across the city from all the various different community boards. Most of those requests do not get funded. The Borough President would like to be able to incorporate a number of them into sort of pockets that they can look at. Hate is a very big agenda for the Borough President, and so is the issue of healthcare. So is there anything on capital expenses can mean anything from capital type things to paying for an intern or paying for a staff person to work on something. Again, I'm going over what David explained to me. It's sort of a very fungible thing. So is there any expenses, anything that we would like to request from the Borough President, or to have the Borough President request from city agencies around the city around the issue of healthcare that's on your agenda?
I think we should request money for the conference, and as you had mentioned, and is Margaret Della's committee also working on that?
No.
Because it sounded like it last night that they were going to be addressing issues of hate.
They're going to be addressing issues of hate, so I'm going to reach out to them to find out what they had on their agenda. Perhaps they'd like to join us, because it's hate, and we're taking a particular tack towards what was suggested to us is the issue of healthcare within the context of the impacts of hate and trauma. So I will certainly reach out to them to find out what their thinking is. Besides the conference and asking for some funding for the conference, and I will write this up and submit it, is there any other issue? Yeah.
Opioid crisis. Availability in the community board for Narcan and testing for fentanyl, the testing strips and things like that.
Think of that, yeah.
I believe getting testing strips is kind of like difficult. mostly in the neighborhood, maybe closer to.
We've seen them in the bathrooms at bars.
Yes, but those are Narcans, right? But they also sell this testing kits where you could have a drug and then you can dilute it and then you could put the strip in and find out if there's fentanyl in it before you even use it, right? So just making sure that that is available in the neighborhood and it's easily available.
So, two things, is, availability,
Easily available.
Narcan
And,
and fentanyl testing strips.
and overall awareness and, education. Whether it's
Materials.
schools or in the communities.
How to use it.
I'm gonna blame it on him. So the question is, I have to find out which agency that would come from. I imagine DOHMH.
It might come from the state, Oasis. It might be at a state level.
That's not something we can request. We can only request from the
Right.
city. So, I will find out which agency in the city constellation provides those kinds of things.
Now, I'm
yeah,
sorry.
Please.
I want to add or put into the mix before we go too far. I received this email from ICNY, Interfaith Center of New York. Are you aware of that? It's Disarming Hate series.
Just want to let you guys know that the senator is trying to log on.
Okay. Let me let him in. I'm very familiar with the Interfaith Center.
I thought that might be something we ought to know, what's in the series. We don't want to duplicate it.
Well, I will take a look at, on my own,
Yeah, absolutely. I wanted to bring it to our attention.
why don't we put this on hold for a little bit while the senator's here? We want to, you have to excuse me, somebody gave me a nice ice cream, and I'm navigating around it. However, we'd like to welcome Senator Gustavo Rivera, who's the chair of the Health Committee in the New York State Senate. We asked the senator to come here and discuss certain areas, and there'll be obviously other questions. But some of the areas that we asked him to discuss, based upon our discussions here, was the issue of health care for all and the legislation that is being proposed, and the issue of healthcare disparities, particularly not only within your district, but within the Bronx itself, and the how that's being addressed through the state. So there are several other areas that I'm sure you want to bring up with your agenda with healthcare. So I'd like to turn this piece over to the senator. And thank you very much for joining us this evening.
Absolutely. Good evening to one and all. Greetings from the white northern plains, up all the way up here in Albany. Since we're in a weird situation right now. It's April 10th. We're supposed to have a budget by April 1st. We didn't do that, and we have an extender that expires on Friday. So we're coming back tomorrow for session to vote on it for the Senate. And it didn't make sense for me to I was here yesterday for session, had work to do, et cetera. And it made no sense for me to go back home and then come back either tonight or tomorrow morning. So that's why I'm still up here. If not, I would be there physically. But thank you for, giving me an opportunity to be with you this evening. I'll just say a couple of things off the top, and then, we can have a conversation however you'd like to do. As you said, there's certainly, I'll start with the budget since I was just talking about that. There are still a lot of unresolved issues, and unfortunately, many of them are around healthcare generally and Medicaid specifically. There are cuts that the governor insists on making, something in the neighborhood of about $1.2 billion that the governor's asking for us to make in the Medicaid system, which which are, I don't think make any freaking sense at all. I'm, and I've been, there's a lot of conversations that are happening around this. And in many of these instances, the Senate is the one that's kind of holding the line, on trying to make sure that these things don't go through, or at least if they do, that they're less harmful. Not only are we talking about raising Medicaid rates, we're also talking about some programs to protect vulnerable people. For example, something called CDPAP, which is the Consumer Directed Assistance Program, that the governor just seems intent on getting rid of. And we're having a lot of issues fighting around that. Um, there are there's a there's another issue which we're trying to secure federal dollars to extend the essential plan to undocumented people, something called covered. It would be over $400 million of federal money that we could use to extend care. We could extend the essential plan to undocumented folks who currently, when they get sick, they wind up in emergency rooms, and we wind up paying for it anyway. Uh, just 2 years ago, to the tune of over $800 million in the state. So we need to, that's another thing that the governor refuses to do, and yet we're trying to get her to do. There's also cuts to home care, um, potential wage cuts. There's just a lot of stuff that we're trying to get through. Um, and I'm hoping that this is something that we can resolve. There's been some progress, but still things are really up in the air. So not sure when we're going to get a budget, probably by next week at the earliest. But I'm gonna be here until tomorrow, then and then going back to the Bronx and coming back on Sunday evening for what will be hopefully a productive week next week. But those are just some of the big some of the things that we're fighting for in this particular budget. As it relates to some of the stuff that I'm fighting for for the entire year, as you were mentioning, there's probably referring to my bill called the New York Health Act, which is a bill that would create a single payer system in the state of New York, therefore guaranteeing healthcare to every single New Yorker. I have actually been making some interesting progress on this in the last couple of months, and I'm very excited about some of the stuff that's happening behind the scenes, particularly as it relates to getting folks who have been on the fence, uh, to engage in good faith on the bill, particularly in some public sector unions. So I am cautiously optimistic of some of the progress that we're making there. And I'm hoping that we can actually, do some more with this bill and have good progress on it this year. There's a couple of other bills that I've introduced that I'll talk about briefly, and then I'll pass it over to you. There's some that I introduced just recently, one a couple of months ago, very much in line with what we're doing with the idea of the New York Health Act. At the core of it is to remove insurance companies from their middle place in the healthcare system, the way that they currently are. I believe that insurance companies there's a lot of bad actors out there, but I think that the insurance companies are kind of the worst actors. And one of the things that they've done in the system, as it relates to long-term care, there's things called managed long-term care plans that I believe have been a failed experiment in the state of New York. And so I've introduced a bill to get rid of them and to have long-term care patients transition back to a fee-for-service model that is managed by the state, as opposed to having a group of insurance companies, middlemen, kind of siphon off, just in I think the last 4 years, it was like $6 billion total that could then go to workers who take care of these folks and to the care of people in long-term care. So that's a bill that I introduced just a couple of months ago, and a bill that I introduced just a few weeks ago, which I also think is very important, is a hospital closure bill. That is a bill in response to what has happened across the state, where a lot of institutions, a lot of healthcare institutions have closed either totally or have closed parts of their facility without any real involvement from the folks who are going to be impacted by it. And I feel that there needs to be a process that is much more thorough, and that, again, centers the individuals who are going to be impacted by whatever closure happens at that hospital, whether we're talking about in downstate, Brooklyn, when we have the SUNY downstate, which is potentially closing, and we're fighting that in the budget as well, or a maternity program somewhere in the Hudson Valley, or some other emergency room in the northern country, et cetera. I believe there needs to be a set process, and we introduced a bill to do just that. So those are just some of the things that I'm working on. But I'm certainly, I'm thankful for this conversation, since it's always important to me to make sure that a lot of the stuff that we do here, and certainly the stuff that I do up here, is driven by the things that are impacting my constituency. So having these conversations is always helpful, and I'm thankful for them. And yeah, so those are just a few of the things I'm working on off the top of my head, and I'm more than willing to have any conversation. Thank you for having me.
Let me just ask a few questions and turn it over to everyone else. First of all, if you could elaborate more on what exactly, when you say that the insurance companies would be taken out of the middle road or the middle person with healthcare, how would that? Who would in fact insure people in the state? Would there be the elimination of the healthcare, insurance companies? How would that play out? And what would be the implications for literally the hundreds of thousands of people who are presently uninsured in New York?
So, one of the main issues that has been challenging about this particular bill is the notion, and it's kind of underlining what you're saying right there, which is a notion that is kind of built into all of us, that the way to get good healthcare is to get good insurance. I believe that anybody, that if you ask yourself, you just ask yourself a couple of questions, or anybody who has insurance, whether it guarantees them care, can tell you that that's not the truth. An insurance company's business model is built around denying you care. They don't make money when they pay for medical procedures. They make money when they deny medical procedures. And so I believe that they need to be taken out of the equation. What I think we should do is we should transition to a single payer system. What we currently have is a multi-payer system. And what that means is that as a provider can get paid out of your pocket, can get paid by an insurance company, can get paid by the state if it's Medicaid, for example, or the VA, or can get, there's a lot of different ways that the provider gets paid. A single payer system means one entity pays the bills, the state. So the state paying the bills doesn't mean they control your health care. It means that they just pay the bills. It's a way to actually simplify the system. So yes, I want to excise insurance companies from the whole equation. Insurance companies, once again, are not in the business of providing you care. They make money when they deny you care. And so I want to destroy their business model, and I'm very clear about that. And I want to excise them from the entire procedure. And I'll just say that this is a version of this exists in basically every modern democracy in the world. If you believe that healthcare is a human right, then we have to go away from a system that centers profit, because that's what the problem is here. And that, whether you're in Japan, in Canada, in Italy, in Britain, in Taiwan, there is a version of a system which is a single payer system. There's different ways to do it, but all of them start with the notion that if you are sick, you should get treatment. Not if you have the right insurance, you should get treatment. See what I'm saying?
Yeah, I couldn't agree with you more about it being a human right. And the other part about it, the way I understand my insurance, is that even though I have insurance, it doesn't mean that it doesn't cost me anything. It costs me quite a bit to be able to get to the other side of getting health care, where I have to think twice about getting X, Y, or Z, because then you have to you fulfill your deductible, and then there's the out-of-pocket, and there's this and that, and then there was this wonderful fight between United Healthcare and the Mount Sinai system, which threw a lot of people, if not
the one that just happened,
people into a panic.
Or the one that happened last year in the Bronx with Monty. So you got Montefiore, which is a provider for hundreds of thousands of New Yorkers, certainly Bronxites and other folks all along the Hudson Valley. And United Healthcare was like, yeah, we don't want to contract with you. And they could do that. I mean, it took months and they ultimately negotiated and they came to an agreement. But you should not, if you have to make a decision, and this happens every single day, it's built into our brains that it's the way it works, but we shouldn't work like this. If you have to make a decision, I can understand you making a decision about whether you're going to I'm going to go and get a burger at the local diner, or I'm going to go to, a 5-star restaurant in the city. If you got the money to do the $500 meal, God bless you. If you got $8 or $10 and you can get that burger at the corner deli or whatever, that's the decision that you can make. But healthcare doesn't work like that, because you might need the equivalent of the damn $500 meal. And if you have that, all of a sudden, and you don't have the right insurance, so you don't have the product that actually guarantees or gives you access to that, then what happens? And this is what happens because people are only uninsured, they're also underinsured. And one thing quickly that you asked this question, this would actually guarantee healthcare, period, for anybody who is a New Yorker, either full-time resident in the state of New York or full-time employed in the state of New York, regardless of your age, your gender, your wealth, or your immigration status. So that would be included in the mix. I can't hear you. I don't know if you're speaking. I can't hear you.
Okay, any questions from, yeah, please.
Yeah, I have a question. Senator Rivera, just wanted to bring to your attention for OPWDD in this budget. From what I'm hearing is there was a 3.2 COLA with a lot of restrictions on it for that category. But if you notice, we have so many people who depend on this budget, even in our district. And I recently came across families where individuals, their loved ones are supported in psych wards in the Bronx. And they've been living in psych wards for 2 years, unable to get into a group home because of the difficulties they have, and the agencies that are willing to support them are underfunded. So the system is close to a near collapse. And there has been a lot of lobbying this year, but from what I understood last week, it is 3.2, but it is a restricted, it's not across the board COLA. Do you have any information on this?
On this one in particular, I know that there was a proposed that there was a COLA that was proposed by us in the Senate. To back up for a second, does everybody understand generally how the budget process works up here? So just really quickly,
Yeah.
the governor presents at the beginning of the year, has a state of the state, basically saying, this is what I want to do this year. A couple of weeks later, she comes back and says, okay, this is how I'm going to pay for it. So that's the budget. Then we have a series of hearings, public hearings for about a month. And so we have public and private conversations about what the budget looks like in every single angle, health, transportation, et cetera, et cetera, et cetera. Then 30 days after the initial budget is presented, the governor says, okay. I've heard everything you got to say. This is my last offer. And then she presents what's known as a 30-day amendment. So that means her version of what she wants to do. Then the Senate and the Assembly do our version of a budget, and we call that the one house. So we say in our one house budget in the Senate, we respond to the governor's proposal by saying we want to do this, we don't want to do that. Assembly does the same thing. So now we have 3 versions of a budget, and then we negotiate, which is what we're doing right now. So I say all of that to say that in our response, I don't remember what was originally in the governor's budget, but in our response in the one house, if I'm not mistaken, we actually did a little bit above that in the COLA for workers in the in that agency. But I'd have to get back to you because it's something that falls not necessarily under my table. So stuff that has to do with the Medicaid program, hospitals, nursing homes, that type of stuff is the things I'm paying really close attention to. OPWDD is a little bit outside of my purview. I can get back to you with it, but I'm pretty sure that we responded in our one house with a higher increase than the governor had on her original budget.
Yeah. Senator, the issue is it is not across the board COLA, which means that the workers might get that 3.2% increase, but it does not pay for other increases, inflation-related increases for the providers or the employers. So it is going to make it some difference for the workers, but the system at large is at risk. So that there is a language which is restricting the use of COLA, which is worrisome.
So that's the thing that you're concerned about, the language that restricts the use of that particular code.
Only to certain workers, not across the board. COLA used to be across the board. So whether your electricity went up, your cost of running office went up, or repairs, whatever you have to pay, it does not adjust to that.
So I'll get back to you about what is in there, because I don't remember right now, but I'll get back to you on it. Like, Brent, make sure that I close the loop on this tomorrow, and then we get back. The gentleman?
Restricted to like the 200
Yeah.
class workers.
Yeah,
So it's restricted to frontline workers, the 200 series workers, meaning that they have to be directly in service
Yeah.
or working directly with consumers or participants in the program. So that's how the previous COLA was. And allegedly there was going to be additional COLAs that would expand it beyond, because you have supervisors or other people in the program who pitch in because there's a lot of open positions, et cetera, but because they're classed differently, they're not eligible for the COLA. So you have this tension between frontline staff who are getting, pretty sizable COLAs, and then you have supervisors or other people a part of the programs that are not eligible for it. So I think that's ultimately.
Yeah, and also the other cost associated
Yeah.
with, it only pays for one part of it, which is not bad, but it's not going to solve the issue and take the field out of crisis that we are seeing now.
So sometimes with COLAs, you see that the state or the city give a portion towards your expenses that go up as well. So that's kind of what the issue is. But I want to picking up where Sebastian left off and sort of connecting to your point on the single payer system. I'm working with organizations that are trying to help individuals with disabilities move out of nursing homes back into the community. And the money that was promised to us to be able to do that is frozen at the state level. They've suspended funding for this kind of program for individuals with Medicaid. Organizations that are small or medium-sized are waiting on millions of dollars for the state to pay them. So have you thought about, in a single-payer system, where I can understand that the trepidation of moving away from insurance companies where the state pays for everything, have you thought about coupling it with sort of good governance or holding the state accountable to its bills and to the, making sure that organizations are not hamstrung by the state payments? Because organizations can't operate where, you're fronting all this money, and then the state of New York is saying we'll pay you whenever we get to it. So it's.
Yeah, that's not, first of all, it's not acceptable, number one. Number two, we should actually, is this something, you brought this to our attention before, have you not? Have we, because if there's a particular case that you'd want to, we may be able to get, my staff and myself might be able to get involved to kind of figure out what's going on. Now, but as far as accountability, it's I would say that it's obviously important to make sure that we have a system that actually responds to the things that are actually happening on the ground. Part of that has to do with the way that the system would be structured. Not only would it serve everybody, but the board that would run the system it would be representative of a lot of different sectors that are responsible for both running the system and operating it, so that it would be, hopefully would be more responsive. And I'm certainly not claiming that anything run by the state would be a perfect thing. But I do believe that for example, in instances like this, I don't know about this particular situation that you're referring to, but there's been many instances in which we've been able to, my staff and myself have been able to involve ourselves and get state agencies that might be stuck on a particular thing to actually do something much more quickly, to be able to have funds that organizations need and have and legitimately have legitimately asked for or been been assigned to actually flow to them. So we might, I'd want to get more into the particular situations that you're referring to. So I'd ask you to
I
please
want
reach out to us. Please reach out to us.
You have additional questions? Okay, I want to back into that a little bit about governance, because that's a really important issue. Full disclosure, I sit on the board of NYU Langone's FQHC and their Brooklyn Hospital. So I
Yep.
look at these budgets all the time, and I'm always concerned about reimbursements. So when the two most reliable forms of reimbursement right now is Medicare and Medicaid. And although they're lower level reimbursements, in other words, they're not paying as much as sometimes the insurers are, they're reliable because you get them on a regular basis. It's not, which is not always the guarantee coming from the insurance companies.
Right.
Are you looking at a similar type of model that the federal government has developed to ensure that those payments are coming into the institutions on this regular basis? Because what Margaret just described is not just endemic to on a state level, where sometimes you have to wait a year to be reimbursed for delivery on services. It's compounded by the weight that the city provides at the same time. So often a smaller not-for-profit, or even a large not-for-profit, has to wait a period of time for any sort of reimbursement from the government, and that does not allow it to either expand services or provide the services that it needs to, and it becomes sort of a catch-22. I think if we really get down to some of the brass tacks of healthcare disparities in the Bronx or anywhere else, it's because smaller, more trusted not-for-profits can't operate in this system because of the delay in reimbursement. So anything that you're going to bring out would have to have the reliability of the federal government's system as opposed to how people are now viewing the state. I think that's where a lot of the hesitancy really resides.
Which is, it's valid, and it certainly will be part of the consideration of how exactly the thing is set up. Part of it is that since we're looking at a system that ultimately will serve everybody, whether you're the governor or whether you're an undocumented person, that's a delivery worker or what have you, and everything in between, that's part of, we believe that that's part of the thing that's going to make sure that the system actually is responsive, since it means that we're going to be pressuring it to make sure that it does the things that it needs to do on an effective basis. But again, part of it is the way that the board is structured. It would be the board's responsibility to actually run the system, and part of it would be the payment methodology and timing of those payments. That'll be part of it, but that's very much a lot further down the field. For the moment, I'm just trying to get folks, kind of bought into the idea that this is a possibility and that it can be done. And that's, that's kind of what that's what I'm trying to build at this moment. And I got about a couple more minutes before I need to go, because I have to go eat, because I'm still at the office and I have to go get something to eat.
Totally understand. Are there any other additional questions for the senator? Well, I really thank you, Senator Rivera. I wish you luck in convincing people, because you're right. Every major democracy except for the United States has healthcare for all built into it. I will say that in some of the ones that I have observed also have the wealthier get a little bit more because they can buy a little bit more, but that's just the reality of the way the world works. But I think that the issue of healthcare disparities in the Bronx is really based upon the inequities in the ability to pay, and the fear of bills that will be accrued because the insurance companies, as you said it so well, deny, and then even though they say they're going to pay X amount, all of a sudden you're stacked up against $10,000-$20,000 worth of medical expenses when you didn't think you had any. I've been there.
There's also
myself. So
there's also some work that I'm doing around medical debt. I passed a couple of bills in the last couple of years. One that the two that the governor has signed in the last couple of years. One, to make sure that the hospitals can no longer put like a lien on your home or garnish your wages, which is something they could do before. That has changed the state of New York. We changed that with the bill that I passed. And another one that would make it so that your medical debt would not be reported to credit agencies. So those are two things. And then we're actually trying to get in the budget right now, credit where credit is due. The governor is it included a lot of medical debt stuff in her budget, a lot of which, to be honest, comes from bills that I've been introducing the last couple of years, but I don't care. The thing passes and it goes forward. So there's a whole bunch of stuff that's in the budget right now that I'm like, that looks really good as far as potentially becoming a reality that will deal with issues of medical debt. So, I think the medical debt is obscene and we need to get rid of it, which is the reason why we need to move to a single payer system. But until we're there, protecting people from medical debt and helping them be able to pay it, that's kind of what we're trying to do.
Well, thank you very much, Senator, and good luck with your dinner tonight, and of course the long-term negotiations on making sure that we are moving forward in this arena, because healthcare is a human right.
Indeed it is.
Thank you.
Thank you so much, folks. I look forward to seeing you in person real soon.
Thank you.
Have a good night.
Thank you.
Well, that was extremely enlightening. I really hope. I have to admit, full disclosure, I sat on the board of an HMO for about 15 years, but it was a not-for-profit HMO. It was the old Health Plus. And then they were taken over by AmeriCare, and it became a for-profit company, and it just became disastrous. It's just really something that you wouldn't want to have anything to do with or be connected to. It is really obscenity is a I would say a light word for it.
And to deconstruct managed care, that would be great.
Yeah.
Oh, absolutely.
Oh, Lord.
Yeah.
Oh, Lord.
There are a lot of advantages to the single-payer system because all the money gets funneled to the state. So your contributions, Medicare, Medicaid, all of that goes to the state. And then the state pays the providers.
Right.
The state doesn't actually provide in most cases. We do in the city because we have city-run hospitals. But the state is the one who distributes and makes sure people get paid.
Mm-hmm.
Well, see, it would be the highest cost center for state government. However, you're saying that there is the income for it. I know that people don't realize that Medicare and Medicaid are the highest cost centers for the federal government.
Yeah, and there's income from Medicaid and Medicare, but there's also the money that I paid every month when I was at Fordham,
Right.
and that Fordham contributed. And that money also goes, it doesn't go to United Health, it goes directly to the government, who use all of those funds to then pay for my costs. So there isn't the middleman saying you can have it or you can't. There's the issue of government bureaucracy, if you will, that people get wrong in terms of getting it done.
Right.
But I think it's a much more secure system. It's cheaper because you don't have that middleman.
Mm-hmm.
That's my basic understanding.
Brett, you have something you wanted to add?
Yeah, I just wanted to say that if you guys, just in case you don't have it, I want to give you guys a couple of email addresses and our phone number as well, so that way if you want to reach us anytime. For my government email, it's my last name minus the R, so it's SCHNEIDE at nysenate.gov. If you're interested in scheduling a legislative meeting with the senator, you can email our director of strategy, Flavia Salazar, at schedulingsenatorrivera@gmail.com. You can always call our district office at 718-933-2034. And if there's any other constituent issue, you can also email grivera@nysenate.gov.
So, Fred, if you can send all that to me in an email, I will distribute it to the committee.
Fantastic. Thank you so much, Rabbi.
I really appreciate it. Thank you so much. And thank you for
Have a good
getting
night,
the
guys.
senator here today. I'm sure he's a hungry guy right now. So,
Yes, indeed.
thank you. Yeah. Listen, it's obviously not gonna happen this year, and it's been a long, long haul. It's his real challenge, and it's not, he didn't start it. It was something that started under his predecessor. I really hope that we get to that level.
He's been working on it for years.
That's my own personal thing. I mean,
He's been working on it for years, to my knowledge.
and the issue that you brought up, I mean, the reality is that there's a crumbling system out there.
Mm-hmm.
And the fact that it's a crumbling system out there, I'll just give you an example. Yesterday, through one of our efforts at GCRC, where I work, we had the New York Jewish Coalition on Criminal Justice Reform. So we met with the new Commissioner of Corrections, and we went out to Rikers. And they took us around Rikers for a couple hours. I'll tell you, it's put a lot of paint on a lot of hallways that they didn't have painted up until very recently. But we talked about healthcare, and we talked about mental health care. And from what I understood if I understood her correctly, more than 60% of the population at Rikers have mental health issues. And as we know that they come from 5 specific zip codes in New York City, the majority of those who are incarcerated in New York State or in New York City, certainly, remember, Rikers is a jail, not a prison, so you're there. Ostensibly, you're there for a short time, but some people we met were there for 3, 4, 5 years as they're waiting trial. There's no such thing as a quick and speedy trial in New York State anymore. I'm not sure there is anywhere in America. However, if 60% of the population there come with mental health issues, they come from areas with poor mental health to begin with, and stigmatization around mental health and all that kind of stuff, and the inability to access good health care in general. And the other issue that we heard loud and clear is sort of turn my head around. If, let's say you're 20 years old and you committed a serious crime and you're now incarcerated for 20 to 30 years. So the healthcare system in the prison system, New York State prison system, is horrid. So none of the transitional healthcare screenings or any of the other healthcare stuff that happens normatively, at least hopefully normatively for most, as you age, are provided to these people. So they're now aged out. They're 50s, 60s. That's when healthcare starts to decline a little bit, and they're now released back into communities where healthcare, especially geriatric healthcare, is really, really poor. So it's just a horrid cycle. I was listening to this being described yesterday, and it was just like, you know, your head is in your hands, but there's not a damn thing you can do about it. And then there was one guy walked over to us, and he had a boot on, and he had a cast on his leg, and he said, "Well, I fell out of a 4th floor window." I said, "How did that happen?" He said, "Well, the police were coming for me, and I felt it was better for me to go out the 4th floor window than to have them beat me up." And we're like, "I'm not sure you made the right choice." But he obviously has serious issues with his ankle and his leg now. Will they ever heal? I don't know. Yeah. That's a real question. So he was admitted into one of the city hospitals for a couple of weeks for some surgery and interventions, but there's literally no follow-up, PT or anything like that in the jail itself. So it's like, it's anyone's guess. So that's a whole other aspect that particularly affects the Bronx in a very heavy way because of the population, you know, the neighborhood pipeline to prison that we always talk about. So, yeah, it's intractable. I'm not quite even sure how to wrap my head around what a solution would look like. Let's go back to the notion of where we want to have to get back to David Geffen. And so we're talking about 2 major areas that we're going to be looking at. We're going to be looking at the availability of Narcan and pet strips of fentanyl in various different drugs. We're talking about requesting some funds, and we want to talk to you in your role as special committee as well. The two committees work together on this issue of hate. It's probably not going to happen in the next month or so, but I know that we can request some funding from OPHC, the Office of Prevention of Hate Crimes, and when Hassan Naveed was here, he is really behind this 100%. I think it's really radically important, and I spoke to the borough president about it as well, and she seems to be, and the DA, and they both seem to be very open to this. The DA, I want to tell you, I don't know how many of you know Darcel Clark. She is really into this issue. She is really, just her whole background is really amazing rise from poverty to where she sits today. So I'll write these up, I'll submit them, and we'll see how much we can actually get. There's no guarantees or anything, although I think that the OPHC money would be something we could probably access for some sort of forum, so that would include both a live and an online forum.
That sounds very realistic.
It would be really important. So, Margaret, what are the issues that your committee is working on around hate in general?
Well, some of the things that we talked about, sort of I relayed what we had been talking about in this committee to my colleagues on SCREE, and we started to talk about several different issues, like individuals suffering with suicide ideation, sort of the internal and external dynamics of hate, or sort of what I guess just describe as hate. So we started to look at ways that we could be supporting individuals with resources in the community. So creating sort of a resource guide where folks could go to, if you are the victim of a hate crime, how you can easily go and, not easily, but, as easy as possible, report the crime, the resources that you have, a bunch of different city-led agencies, and for all sorts of ways in which you can get support. Then, suicide intervention, or getting support on mental health, veterans issues, certainly, as that's something that is a national endemic in terms of suicides by veterans, and also guns. So all of a sudden it sort of morphed into this conversation on every single component within the community. And so looking at ways in which each committee could take on an aspect of hate and how it permeates through the community through the lens of each committee.
It's interesting how you say that it all becomes intersectional. Also, another aspect we're working on within the work that I do is on the issue of gun violence. And we're working very closely with Northwell, because Northwell has taken on one of the biggest aspects of, Michael Dowling, the head of Northwell, has taken on gun violence as a national emergency. And we held a conference last May, at UJA Federation. We did this through our agency. He was a keynote speaker, and he said when he first started, everyone was looking at the issue of gun violence through the issue of gun control. He said, no, we're not talking about gun control. We understand that we're not going to get into this whole, Second Amendment stuff. We're not going to get into all the other stuff. We're talking about the impact of gun violence, and gun violence obviously plays out big time with and the largest. Oh, so I'll ask the pop question. Does anybody know that you're not allowed to answer because you know the answer? Does anybody know the largest percentage of deaths incurred by gun violence? What issue it is? Suicide. And it's like over 50%. And a lot of it has to do with the kinds of issues you just laid out there. So I think it might be very helpful. Perhaps we could have a joint meeting between our two committees and really do some substantive planning about something that would happen in the fall The issue is obviously not going away. It's high on the agenda, I know, of the mayor. It's high on the agenda of the commission, where I'm one of the commissioners on human rights. So certainly on the work that we're doing as well. I think it's something that really has to be explained to people. One of my fellowships today, we had, and just sort of serendipitously, we had our training around hate crimes in the Brooklyn DA's office. People just like their jaws dropped because of the intricacies, of hate crimes and the impact it has upon people. I'll give you one example, because he brilliantly, horribly, but brilliantly talked about, kept asking them, is this a hate crime? Is this not a hate crime? There was one hate crime they were talking about. Two guys, one of them is visiting from out of state, and two guys are hanging out, and one of them gets hungry, so let's go down to the bodega. Down to the bodega. There's inside the bodega is a guy who is, he's, as they said, obviously exhibiting certain LGBTQ, traits. Clothing he's wearing, affectations, all kinds of stuff like that. And one of the guys who was hungry starts peppering him, with insults and stuff that would be considered free speech at that point. It was, and it quickly escalated into violence. It beat the living daylights out of this guy, and his partner as well. The head of the head of the bodega, the guy who was running the bodega, watched the whole thing, did not call 911, because people will not call 911. There's another issue of bystanding training that we might want to take a look at and bringing in. How do you be a proper bystander within the context of society? And then there was a real debate. Was this all precipitated because of hate, or was this another issue? And there was a big debate amongst the prosecutors, what they do. And because of all, the pleading out and this thing and that thing, neither one of the people who attacked this man were charged with a hate crime, because they couldn't convince the grand jury that it was a hate crime, even though they had all this stuff, because people don't understand what hate crimes are really all about, and there's certain unconscious bias, so certain prejudicial acts against certain populations within the hate crime legislation are less prosecutable than others. They did get convicted, both of the guys who beating on this one person of assault, but it did not have the when you have a hate crime, you're
7 years.
You boost it up another. Either 7 years or you boost it into another category. So if it's a second-degree felony, it becomes a first-degree felony, or if it's a misdemeanor, it becomes a felony or something like that. I forget what the exact. But it's really scary stuff. So even to educate people on what a hate crime is.
I think part of the problem I'm hearing is, one, we're not clear. We don't have a good definition of a hate crime. How do we know?
We don't. The government does. Yeah. I mean, there's real hate crime legislation, yeah.
But it's probably wobbly enough with enough interpretation.
Yeah.
And the second thing is, you're lumping all hate crimes together. And they're not, I'm wondering, I'm posing these as questions, especially at this hour.
Yeah.
They're not all the same. Are there differences, and do they have different impacts? Does a constant barrage of microaggressions have an impact on me that's different from a really from a hate crime that leaves me with PTSD, traumatizes me? Am I making sense? Not all, Anyway, I'm going to stop here.
So, just to address it briefly, a couple of things. One is, you're correct that a lot of it's called wobbliness, because remember, it's a grand jury that ultimately decides. The initial investigation of something that could be considered hate crime is done by the sergeant, and it has to be the sergeant then referring it to the captain. So there has to be a designation by the officers investigating, and then they bring it to the DA, ultimately charges, and then they have to bring it to a grand jury, and the grand jury has to accept whether they have enough proof to say that the reason for the crime was not because they wanted to get the guy's wallet or they wanted to do this or that, it was instigated through hate. That was the wobbliness, to use your language, of this particular case. You know, because it could have been, remember, we're dealing today with altercations being videoed, but without sound. So you just don't know. And there could have been some exchanges that were going on before that, and that's just a whole bunch of stuff that goes on around this kind of thing. To understand this, because people are traumatized, to put it well, by the issue of hate crimes in general. And particularly communities that have a long history of hate directed at them, whether it's the LGBTQ community, whether it's certain racial groups, certain faith groups, immediately jump to the hate crime as being what happens. But hate crimes in New York State are very specific as to their causation and the sort of the going from point A to point Z to prove exactly what a hate crime is. Understanding it becomes difficult.
Yeah.
And there's a lot of pushback. For instance, and I won't use what happened up here in Riverdale. I'll use a very different example. There was a young Sikh man that was beaten up in Jackson Heights, very seriously beaten up. They didn't charge it as a hate crime, and the community was beside itself. It's like, what's going on here? How come you're prejudiced against us because you think we look like this and we do this? And the head of hate crimes didn't quite know how to explain it to the leadership. What it was is that the kid that was beaten up wasn't wearing any identifying clothing. It was for someone to figure out that he's a Sikh. So it couldn't have been charged as a hate crime against him as a Sikh. Now, he's South Asian, so there could have been something around that. But it turned out it was a gang initiation.
Oh.
And the people that had been arrested before for leading different other gang initiations in that particular area. The Hate Crimes Bureau determined it was a gang initiation. They just got two guys walking down the block who just happened to be Sikh, but wasn't wearing any identifying clothing, wasn't wearing the turban, all that sort of stuff. So it was not identifiable. And younger, he was the younger Sikh, and he didn't necessarily have the long hair or the beard or all that kind of stuff. And didn't necessarily, they're not going to see his various different other kinds of accoutrements. And being able to explain that to the community is very hard. Now, the people were prosecuted, but they weren't prosecuted as a hate crime.
My husband's waiting for me.
Gotcha.
I'm sorry.
So, Margaret, if we can get the two committees to meet together sometime, figure out when would be an appropriate time in May or June, I think that would be helpful.
And, yeah, definitely. And we started putting together.
How often does your committee meet?
We meet 4 times a year.
Oh, so, yeah.
So we have a meeting tomorrow, and then in May. So we could perhaps have a joint meeting in, usually in May we work on the report, but we could meet in May when we all meet together, or in June.
Or June. So,
Yeah.
so I'll be in touch with you. We can figure
Okay.
that out.
And
Speak to your committee, you know.
Sorry to interrupt you.
Yeah.
Because you all are so knowledgeable about different resources in the community, if I could share this, like, nascent document with you all, and you could just, like, plop things in.
Oh, sure.
You know, all of the various areas where you have experience, you know, if it's Oasis or recovery or all of the work that you're doing, like anything that you all want to drop in there. Like I was taking some notes, just the things that you were running down today that I think we haven't added, but then I can just add them more succinctly, and then we can, you know, polish them off a little bit more and make something that's a comprehensive document.
That
So,
would be my pleasure.
thank you.
This,
You sign up for that, Josh? You okay with that?
Yeah.
Okay.
It's not gonna happen that easy, but,
No.
it's just really scary stuff that's happening, and, one of the biggest challenges, again, they were talking about today at the DA's office, was the reporting issue. Is that many people in many different populations simply don't report. And each community has its reasons that it doesn't report, whether it's for immigration issues, it's racial issues, sexual orientation issues, and a whole bunch of various other issues that they don't report, because so then you don't have data.
Yeah.
And if you don't have data, as if it didn't happen, you know? Again, I think that if we really bring together our resources, we can, and then bring in the right types of folks. Like I work very closely with the Justice, U.S. Justice Department on these kinds of issues. Mortimer Latimer is a particular area of expertise. The DA's office has all kinds of stuff that they're doing, and they're really dedicated to this. And so they could be, and of course, Hassan Naveed, although he has OPHC has a lot of purview, has a very small department. However, Human Rights has a much larger department, but we're undergoing now a whole revamping of, rewriting of a lot of our presentations, particularly the one around anti-Semitism, because it's all pre-October and everything has changed since October. So fun stuff, real fun stuff. Okay, so hopefully we appreciated the senator being here, and thank you for all your input. Our next meeting is, let me just take a look, in May 8th. Okay. This is right around the corner, believe it or not.
I may not be able to be here for that meeting.
I may be having a grandchild about that time, so I'll let you know as well, in Chicago, so.
Good for you. Okay. Yeah, that is good.
If not, then we'll meet in June. Okay,
Okay.
we'll figure it out in June.
Good.
Okay.
Well,
Thanks
thank
to
you.
everyone. Well, thanks to everyone. Yeah. Good night, everyone.
Everybody else left.
Well, there's one person that's a participant.
So,
For the